Thank you, Dr. Pauwaa. Thank you, Chad. Thanks so much. Thank you guys all. Thanks for joining us today, and thank you for having me. I'm going to be talking to you guys, as you know, about SGLT2s, kind of picking up where Dr. Lerma left off last week. Got a lot of stuff to cover, so I'm going to just jump right into it. But thank you, Chad, and for all of you guys for having me today. So here are my disclosures. All right. So last week you heard from Dr. Lerma, and I know he was a Spider-Man fan, so I kind of incorporated that into my presentation here. Thought I'd drop a little theme. You know, Dr. Lerma was he gave the, as Chad brought up, the renal aspect of it. And one other thing I wanted to just mention was, you know, so I was going to try to introduce a little bit of a superhero theme here. And actually, one of my good friends and colleagues, Dr. Chris Shamana, who's another one of the advanced heart failure cardiologists, is also a big fan of Spider-Man, and so I've included him here as Dr. Lerma's buddy. But personally, this is my favorite superhero sort of all time. I'm not sure if any of you guys know who this is, but this is Colossus. He's one of the X-Men, and I feel like I have a lot in common with him, specifically physique. I feel like we're both kind of on the same page. Actually, he's a very gentle giant. He's a peaceful man who actually prefers to resolve conflict by peaceful means, but if necessary, is not afraid to flex his iron muscles. So I'm going with Colossus on this one. Lerma can go with Spider-Man, and I'd love to hear what Dr. Krikorian, who's his guy. So to start this lecture, you know, one of the things Dr. Lerma went through the basics of these presentations, or of these drugs, but I think one thing you got to do is first start by learning even how to say them. They're kind of tough to pronounce. They're kind of tough to say when you're trying to tell your patients about them. And there's several of them. And so I thought I'd just kind of go through how to pronounce these meds. So the drugs we're going to be talking about, the SGLT2 inhibitors, are dapagliflozin, which is Farxiga, empagliflozin, which is Jardiance, canagliflozin, which is Invokana, and then there's two other ones, ertugliflozin and sotagliflozin, which there's been more data to come and support those. I'm going to be talking a little bit less about those two, as the cardiovascular benefits are still being established, although are clearly there. But just I thought I'd start by just a simple lesson on how to pronounce these drugs. So as an overview, what we're going to be doing, we're going to be talking about today, we'll be talking about the basic pharmacology, which I know Dr. Lerma spoke to, so I won't go into too much detail. We'll review the cardiovascular outcomes and heart failure outcomes and literature to support them. We're going to talk a little bit about the mechanisms of cardiovascular benefits, which extend beyond the basic pharmacology, and there's a lot of theories to support or to suggest a myriad of benefits from these drugs. And I'll talk about just some of the few more important and more impressive and thoughtful ones that I think really help to explain potentially why these drugs are more than just glucose-lowering agents. We'll go a little bit into the new cardiovascular recommendations regarding the SGLT2Is and how to incorporate them into your daily practice. So just to give you a little bit of background, I'm going to start with a question. So keep in the back of your head as I go through my talk, because whereas we could just say that SGLT2Is are good for your heart and good for diabetes and good for your kidneys, it's always important to understand what specific patients we're talking about. And you know, I thought a question would be a good way to frame your mindset as we go through the different studies, so that you can kind of understand who these drugs are, drugs will benefit, and who the data supports their use in. So SGLT2 inhibitors are rapidly emerging in clinical medicine. Which of the following is true of their role in CV patients? And I won't need an answer. I'm just going to give you, again, just a question. So they improve clinical outcomes in patients with diabetes and risk factors for ASCVD, patients with diabetes and established ASCVD, patients with HFrEF independent of diabetic status, HFpEF and diabetes, HFpEF independent of diabetic status, or either HFrEF or HFpEF independent of diabetic status. So again, I'm not saying that these are the people. I'm saying that think in your mind, who are the people? These are your options, and start thinking about, based on the data that I'm about to present, who are the people who SGLT2Is have been proven to benefit based on the modern data. So the mechanism by which these drugs work, again, is fairly straightforward. I know Dr. Lerma went into this, so I won't go into too much, I won't belabor this too much. The SGLT2 receptor or co-transporter is located in the kidney, specifically in the first segment of the proximal convoluted tubule, and accounts for 90% of reabsorbed glucose. SGLT2 inhibitors inhibit this co-transporter and therefore inhibit glucose reabsorption, leading to glucoseuria, and they also inhibit sodium reabsorption, leading to natriuresis. And that's the primary mechanism by which these drugs, like at the most basic level, exert their pharmacologic effect. By doing so, again, they increase glucoseuria. We already mentioned that. They increase natriuresis. And they have a myriad of other effects, including weight loss, lowering blood pressure, and then ultimately improving CV outcomes and renal outcomes. Now, one thing I also want to point out is there are both the SGLT2 and SGLT1 receptors. The SGLT1 co-transporter, acts as a transporter for glucose absorption, not in the kidneys, but rather, or less in the kidneys and more in the small intestine. The SGLT2 transporter, on the other hand, works primarily for glucose reabsorption in the kidneys. And another thing that Dr. Lerma touched on is that even though a lot of the time we believe, or a lot, in this case, as I'll speak to, we believe a lot of what we're seeing is a class effect, there is a variability in terms of the receptor or co-transporter affinity between the different drugs that we're talking about. So and I've kind of listed the SGLT2 affinity versus over SGLT1 affinity here, empagliflozin having among those strongest, and sotagliflozin having the least affinity for the SGLT2 co-transporter. Just always important to understand how these drugs differentially affect or bind to the co-transporter, much the way you should understand that different beta blockers bind beta 1, beta 2, and alpha receptors, and therefore have a variable effect or a differential effect between the different drugs. So let's go into the evolution of the cardiovascular data with SGLT2 inhibitors. It's been a little bit of a course, or a little bit of a journey throughout these drugs over the last 5 to 10 years, specifically as they pertain to CV outcomes. So it kind of started back in 2015 with the Empa Reg trial, which we'll go into, Empa Reg Outcome trial. Subsequent to that, we had the data from the Canvas program, Vertus CV, the artugliflozin data, and DAPA-HF. And subsequently, we've had a few more studies come out, Credence, Declare-TIMI 58, Emperor-reduced DAPA-CKD, and ultimately, we're currently awaiting the results for Emperor-preserved, the data on empagliflozin in PRESERVE-VF. So we're going to start with Empa Reg Outcome, because this is one of the early trials, as I just mentioned, and really kind of calcified or laid the course for the subsequent trials that we're going to see in the cardiovascular benefits that were demonstrated. So Empa Reg Outcome, in Empa Reg Outcome, there was about 7,000 patients, just over 7,000 patients with diabetes. So remember, these are patients with diabetes type 2, randomized to empagliflozin 10 milligrams, 25 milligrams, or placebo daily. And that was in a 1-to-1-to-1 fashion that they were randomized. The inclusion criteria, which is always important to understand, so you know, again, who these drugs apply to and who you should use them in, were adults with diabetes type 2, over 18 years old. They all had established cardiovascular disease, a BMI less than 45, a GFR greater than or equal to 30, and an A1C between 7 and 10. They had a median of about 3.1-year follow-up, and the primary composite outcome was death from CV causes, non-fatal MI, or non-fatal stroke. Secondary outcomes included primary outcome plus hospitalization for unstable angina, and then they looked at the individuals of death from any cause, death from CV causes, and heart failure hospitalization. I want to emphasize here, you see my little thing growing there, as these are patients with established CV disease. We'll look at the statistics here. So in the baseline characteristics within the supplement, you can see here that upwards of about 98 to 99%, close to 100% of these patients had some form of cardiovascular, what they call risk factors, but quite frankly was active cardiovascular disease. It was either coronary disease, multivessel coronary disease, a prior MI, CABG, stroke, peripheral arterial disease, single vessel coronary disease, or cardiac failure. So in the majority of cases, these patients did, in fact, already have pre-existing atherosclerotic cardiovascular disease. So these were high-risk patients, not just at risk, but who actually had disease. And here's the actual outcomes data, and empagliflozin significantly lowered the risk of the primary outcome, CV death, non-fatal MI, and non-fatal stroke with a p-value of 0.04 for a 14% relative risk reduction. That's what we see in figure A here. We see that those benefits are maintained. They start early and are maintained throughout the entire course of the trial and treatment. What was also interesting is that empagliflozin also significantly reduced death from cardiovascular causes, and in that case, the benefits were fairly profound. Death from any cause with a 32% relative risk reduction, and very importantly, hospitalizations for heart failure with a 35% relative risk reduction. And what was equally impressive in terms of not only the significance is how early these effects were exerted, and ultimately how much they persisted and maintained throughout the entirety of treatment. At no time really the curves really moved together. If anything, with time, placebo outcomes worsened, whereas empagliflozin maintained a much lower risk profile. So this is the first sample or first sort of suggestion that there was really a significant cardiovascular benefit with these drugs over placebo, and that perhaps there's more to these medications than their glucose-lowering effects. When you see this such an early manifestation of these of the benefit, you can't really attribute the entirety of the benefit to just glucose lowering, because as we know, that's going to be something that's going to take time to really reverse the potential impact on cardiovascular outcomes, and sort of raising the question, what are these drugs doing and how are they affecting the heart to manifest such a profound and early benefit? And these benefits were independent of dose, and so that'll be important as you're trying to decide, well, how do you prescribe, what's the dose you do, 10, 25, how do we do it? And really it doesn't even matter. Whether you do 10 or 25, the cardiovascular benefits are clear and are fairly stable. And so the recommendation ultimately is for the 10 milligram dosing. Now when you break down the individual outcomes, we start to see here that death from any cause, as we mentioned, and death from cardiovascular causes was significant. And then that we also see, as I mentioned, the significant benefits of the hospitalizations for heart failure. But we don't see as profound of benefits to things like fatal or non-fatal MIs, which were not significant, non-fatal MI, excluding silent MI, hospitalizations for unstable angina, coronary revasc, strokes, TIAs. In those categories, the SGLT2, specifically empagliflozin in this case, did not seem to offer a benefit. So it raises, again, the question, is this more because of the diabetic effects or something else that it's doing to the heart? And then here again, we see the effect of the drug on A1C. And at most, we're seeing an impact of just over 0.5% lowering of the A1C, which diminishes with time. Again, questioning whether these benefits are truly due to the glucose-lowering effects or something more. Now, just as a little aside, the adverse events seen in this drug with this drug are going to be consistent, at least throughout most of these drugs. And we do see an increase in genital infections, UTIs, and potentially diabetic ketoacidosis. So that is something that needs to be understood and patients need to be counseled, and you do need to understand how to respond and how to counsel your patients as far as potentially how to avoid these side effects and that these side effects may occur, and therefore they need to let you know if an issue shows up. You are increasing glucose concentration in the urine, and therefore this is a genital infection. An increase in genital infections and UTIs is not a surprise. So the takeaway from this trial was in patients with diabetes type 2, established CV disease, empagliflozin 10 or 25 milligrams lowered CV death and non-fatal MI stroke. However, this was driven primarily by CV death. There was a significantly lowered risk of hospitalization for heart failure, but it did not lower the risk of most atherosclerotic outcomes such as MI, angina, PCI or CABG, or stroke. There's only a modest A1C lowering, and again, the UTIs, the increase in UTIs and genital infections were seen. So now we move to Canvas. The Canvas program and Credence. But the Canvas program was combination of two trials, is basically integrated data from two trials, totaling just over 10,000 participants with diabetes and high CV risk. Now, these were patients at risk for atherosclerotic disease or with disease. So this included both those with disease or those at risk for cardiovascular disease. So they all had diabetes. They either had ASCVD or risk factors, including diabetes for over 10 years, hypertension, tobacco use, proteinuria, or dyslipidemia, and the average and the GFR had to be over 30. Primary endpoint was that of death from CV causes, non-fatal MI or non-fatal stroke, and the secondary endpoints were similar to the Empa Reg Outcome: death from any cause, death from CV causes, progression from albuminuria, and a composite of CV death and hospitalizations for heart failure. The background on these patients, there was predominantly male. Almost everybody had hypertension, a small percentage that had heart failure. Most people had diabetes over 10 years. Some people had coronary disease, about 50, just over 50%. And what I want to draw your attention to is that in this study, as opposed to the previous, where we had almost 100% of patients having cardiovascular disease, here we only have about 65%. So this is maybe a slightly lower risk group with several risk factors, but not necessarily defined or diagnosed cardiovascular, atherosclerotic cardiovascular disease. And while the outcomes demonstrated that the canagliflozin did significantly lower the risk of the primary outcome, the combined composite outcome of death from CV causes, non-fatal MI, and non-fatal stroke. When you looked at the individual outcomes, actually it did not significantly lower any individual one significantly. So it's like it brought all three of them down just enough to bring the composite down below to significance. But when they looked at each individual outcome, neither death from CV causes, nor non-fatal stroke, nor non-fatal MI was actually significant. However, we did again see a 33% relative risk reduction in hospitalizations for heart failure. And again, those effects were seen very early in the course, almost immediately after starting the drug. Again, raising the question, what are these drugs doing that they're exerting such a profound benefit so early? And here again, on this forest plot, you see that despite the primary outcome being significant, in most cases they cross one, except with hospitalization for heart failure, where the benefit is much more profound. And when you combine death and cardiovascular causes and hospitalization for heart failure, yes, it's significant. But when they bring into the mix the death from CV causes, it's not as profound of a benefit. So really, it seems like the outcomes are driven by heart failure prevention. So the takeaway here, in patients with diabetes type 2, with established CV disease or multiple risk factors for CV disease, canagliflozin in a dose from 100 to 300 milligrams daily significantly lowered rates of the combined primary outcome of CV death, non-fatal MI, and non-fatal stroke, but did not actually lower the individual outcomes, but did significantly lower the risk of hospitalizations for heart failure. So it prevents heart failure. And again, only a small percentage of these patients actually had heart failure. So in some way, we feel that this might actually imply that this is preventing people from developing heart failure who are otherwise at risk for developing heart failure. So overall, you see a similar trend suggesting a class effect, although maybe the effects weren't as impressive as those with the Empa Reg Outcome. And if that's, and one speculation might be, remember, empagliflozin has a much more strong affinity for the SGLT2 transporter than drugs like canagliflozin. And perhaps that's why the benefit wasn't as profound. Again, here we saw an increase in infectious risk of infection in male genitalia, increased UTIs. But the other side of adverse event that was seen in the Canvas trials that raised some concerns was that there was a significant increase in amputations. And that, of course, brought a lot of concern as we started using these drugs, or they started talking about these cardiovascular benefits, especially since so many of our patients do have PAD and are at risk for this type of a complication. But this was later clarified when they went back and looked at some of this data from Canvas. And in fact, 92% of the patients who eventually had an amputation had a premorbid event of either an infection or an ulcer that was identified. So I think it's important to screen your patients for any potential lower extremity infections or ulcerations, non-healing ulcers, that might increase the risk of amputation, as those seem to be the people at most, that are most susceptible. And when they looked at amputation outcomes in Empa Reg, they were not significantly different from placebo, and that started to fade as a potential concern as long as you screen these patients and make sure that you're using them in the right patients who are potentially at lower risk for lower extremity complications. So then came credence. So in credence, there's about just over 4,000 patients with type 2 diabetes and albuminic CKD. So this was truly more of a renal outcome study. And I know that Dr. Lerma went more into this, so I won't belabor this. These were patients with GFRs of 30 to 90 with proteinuria, treated with RAS blockade, and they were looking at the primary outcomes of ESRD, doubling of creatinine, or death from renal or CV outcomes. And again, we see in this study about 50% of the patients had established cardiovascular disease. So about 50% had, again, this is maybe a little bit less than Canvas, which I put the criteria here for Canvas. 64% or 65% had CV disease in Canvas, nearly 100 in Empa Reg Outcome. And here we have about 50% who actually had cardiovascular disease, but they did have worse renal function than those patients in Canvas. And while I won't go into the primary outcomes with regards to the renal outcomes, as Dr. Lerma had already talked about that, let's just say that there was a borderline significant decrease in the death from cardiovascular causes with a p-value of 0.05, which seemed to merge at the beginning but then separate as time went on. But then again, when you start to look more closely at hospitalizations for heart failure or cardiovascular death combined with hospitalization for heart failure, you do see a significant, much more significant impact of these drugs. Again, probably driven primarily by hospitalizations for heart failure. And just also to mention, they also looked at amputations, and just to clear the air, there was not a significant increase in amputations with canagliflozin over placebo in the credence trial, and so that again calms people down a little bit about that concern. So the takeaway here in patients with diabetes and renal disease, canagliflozin 100 milligrams daily significantly improved renal outcomes and significantly reduced CV death or hospitalization for heart failure, and specifically hospitalization for heart failure. And really, the main thing is that most of these outcomes were driven by a reduction in heart failure hospitalization. So now moving on to Declare TIMI 58, I'm going to skip the DAPA-HF and Emperor reduced, or at least DAPA-HF for the moment, while we talk still about general patients with cardiovascular disease. So Declare TIMI 58, again, 17,000 patients with type 2 diabetes with or at risk for ASCVD, randomized either to dapagliflozin, 10 milligrams daily, or placebo. These patients all had diabetes. They were all over 40. They all had a GFR over 60. They had an A1C of 6.5 to 12, and they either had established ASCVD or risk factors for ASCVD. Primary outcome was composite of CV death or hospitalizations for heart failure and MACE, and the secondary outcomes were renal composite outcome or death from any cause. In this case, there was about 40% with established atherosclerotic disease, so now we're even lower risk category than the 2 prior or 3 prior studies that we've already discussed here. And again, we see a significant benefit in reduction of cardiovascular death or hospitalizations for heart failure. The MACE was the reduction in MACE was not significant compared to placebo. Neither was death from any cause. But again, we see this primary endpoint that's driven by hospitalizations for heart failure. You see that even though the combined endpoint of cardiovascular death and hospitalization for heart failure was significant, when you look just at death for cardiovascular death or for deaths from cardiovascular causes, it's not significantly crosses at 1, but implying that endpoint, that composite endpoint, was most likely driven again by hospitalizations for heart failure. So we're building a real strong argument that this is like an anti-heart failure drug more than anything else. Again, just kind of saw a similar increase in genital urinary infection or genital infections with dapagliflozin again, something you have to keep in mind, but no increase in amputations as we saw in Canvas. So takeaway here, so patients with diabetes at risk or with ASCVD, dapagliflozin 10 milligrams daily significantly lowered rates of CV death or heart failure hospitalization, driven primarily by heart failure hospitalizations, did not significantly impact MACE, did not significantly lower CV death alone. And again, the patients who with established ASCVD seem to have more significant benefits. So now we're going to focus a little bit on heart failure, because after all of these three trials, so basically these three trials, or at least several of these trials had come out, and again, they just kept pointing over and over, there's this heart failure benefit, there's this heart failure benefit, it happens early, and so people started to think, is this drug doing something more, again, to the heart, and should it be considered maybe for drugs for patients who have heart failure but don't necessarily have diabetes? And so that spurred two subsequent trials. The first, DAPA-HF, in which they looked at 4,700 patients with either NYHA class 2, 3, or 4 heart failure. All of these were reduced EF, so that's an important point. Remember, we're thinking we always wanted to differentiate reduced EF from preserved EF trials, and this was one in which the EF cutoff was 40%. They had some NT-proBNP cutoffs. I mentioned the 600. If they had AFib, it had to be 900. There was a variety of NT-proBNP cutoffs that were incorporated into the inclusion criteria. They all had to be on standard of care management, GDMT plus or minus by the ICD as indicated. They had a GFR of greater than equal to 30, and that's important because as you start to decide who to use these drugs on, you want to know what's the cutoff for renal dysfunction. And they either had or did not have. It was sort of regardless of diabetic status. So it's placebo versus dapagliflozin 10. And the median follow-up was about 18.2 months. The primary outcome was composite of worsening heart failure or CV death, and then there was a variety of secondary outcomes, composite of heart failure hospitalizations, CV death, hospitalizations for heart failure, or CV death alone. Now, as far as the background on these patients, predominantly the study was involved patients who were class 2 of heart failure, so it was important to understand the breakdown. Who does this particularly benefit? And this seemed to be primarily an early early trial, a class 2 population, average EF around 30%, and only about 40% of the patients actually had diabetes in this trial. All these patients were on really good medical therapy. Upwards of 90% were on an ACE, ARB, or ARNI. 96% or more were on beta blockers. 71% were on MRAs, which is actually really good for modern heart failure. We oftentimes feel that MRIs are underutilized, and to have 70% utilization is actually fairly strong within a heart failure trial. And about 18 to 19% were on digoxin. And sure enough, the primary outcome was met significantly. So there was a significant reduction in heart failure, worsening heart failure or CV death. When they broke it down, we saw a significant reduction in heart failure, hospitalizations for heart failure, about a 30% relative risk reduction. The impact on death from CV causes was not as profound, but did give you about an 18% relative risk reduction. And again, the death from any causes was also similarly not as profound as the impact on heart failure alone. So here we see this. Break it down again in terms of a 26% relative risk reduction in the primary outcome, implying a number needed to treat of only 21. 30% relative risk reduction in hospitalizations or urgent heart visits for heart failure. 30% relative risk reduction in hospitalizations for heart failure, and an 18% relative risk reduction in CV death. There was also improvements in KCCQ, the quality of life questionnaires. And so that sort of implies not only benefits in terms of the impact to the from a reduction in heart failure, but also a symptomatic benefit to the patient. And I want to emphasize that these benefits were seen. This is the breakdown in subgroups, and I won't go through every single one. But I feel what's most important to highlight is that this benefit was profound, and almost more profound in those who didn't have diabetes than those who did. Basically, it was equally profound, regardless of diabetic status. And so here we definitely are starting to see a detachment of the mechanism from the diabetic impact on diabetes, and more of potentially other benefits of this drug beyond its glucose-lowering capability. As far as safety outcomes are concerned, we did not see, again, an increase in amputations, and for the most part, the drug was fairly safe with regards to renal adverse events, volume depletion, major hypoglycemia. These drugs did not cause significant adverse events with regards to the adverse events that were listed there. So among patients with chronic systolic heart failure, this is sort of the takeaway. Regardless of diabetic status, dapagliflozin 10 reduced risk of worsening heart failure or CV death, hospitalizations for heart failure, CV death, and the composite of heart failure, hospitalization, or CV death. So we're seeing this profound impact on patients with heart failure, regardless of diabetic status. The greatest benefit was in class 2 heart failure, and again, we also saw symptomatic improvement via quality of life scores like the KCCQ. Now moving on to Emperor Reduced, the other of the two heart failure sort of exclusive trials. Again, 3,700 or about 3,700 patients with NYHA class 2, 3, or 4 heart failure, regardless of diabetic status, randomized to empagliflozin 10 daily versus placebo. Inclusion was, as I mentioned, a low EF less than 40%, a recent heart failure hospitalization, a GFR greater than 20 in this case rather than the 30 with DAPA, and these were all adults with elevated BNPs. They followed them for about 16 months. Primary outcome was composite of CV death or hospitalization for worsening heart failure, and the secondary outcome was hospitalizations for heart failure or decline in eGFR. Again, I want to emphasize that these were primarily class 2 patients. This was a mix of ischemics and non-ischemics. They were on good medical therapy for their heart failure. And again, we see a similar outcome with a profound improvement in the primary outcome, as well as significant improvements or reductions in first and recurrent heart failure hospitalization. And in this case, whereas with dapagliflozin, we actually saw an improvement in CV death, unfortunately, in the empagliflozin in the Emperor HF trial, we did not see a significant reduction in actual cardiovascular death. So this was primarily driven, benefits here in terms of the benefit was primarily driven by heart failure hospitalization and not as much by a reduction in cardiovascular death, whereas with dapagliflozin, we saw both a reduction in cardiovascular death as well as that with heart failure hospitalization. Again, seeing a consistent increase in genital infections and potentially UTIs. So the takeaway here, patients with heart failure reduced EF, less than 40%, empagliflozin 10, significantly reduced CV death at the combination endpoint, or the combined endpoint of CV death and heart failure hospitalization, but that was definitely predominantly driven by a reduction in heart failure hospitalization. Only 50% of patients had diabetes, and then there was the increase in complex genital infections. So I kind of won't go too much into the details here in terms of the comparison between the two groups, other than to say that in DAPA-HF, only 40% of patients had diabetes. In Emperor, 50% had diabetes, and yet in both, we still saw a profound benefit, again, making this more and more a heart failure drug or a cardiac drug than a endocrine medication. So what other mechanisms could be at play here? Why are we seeing these profound cardiovascular benefits, and why are we seeing them so early? There are several mechanisms that are thought to play a role in the cardiovascular benefits seen with SGLT2 inhibitors. I'm not going to read, but I will go through in the next few slides several of those that are thought to potentially underlie some of the benefits that I've been kind of sort of emphasizing in all of these trials, that we saw in all of these trials. Osmotic diuresis, there's direct cardiac effects, those on the sympathetic nervous system, efficiency, fuel, cardiometabolics, reduction in inflammation. We're going to go into some of these very fascinating effects here. So first of all, SGLT2 inhibitors definitely do cause, again, we know glucouresis or glucoseuria, as well as natriuresis. But what's interesting is that although they do reduce total body volume, they seemingly do so by reducing interstitial volume just as much, if not more, than intravascular volume. And this is really interesting because, you know, whereas loop diuretics we know are more of an intravascular depleting drug, and whereas those will remove volume at the expense of potentially augmenting your sympathetic nervous system, and we know that loop diuretics in fact increase mortality because they tend to, and the theory is that they increase the RAS and the sympathetic nervous system because they will cause more hypotension, hypovolemia, intravascular hypotension and hypovolemia. SGLT2 inhibitors seem to generate a more, how do we say this, just a reduction in total interstitial volume rather than just exclusively intravascular volume. And this has been studied with drugs like dapagliflozin, where they actually looked at cellular interstitial volume or tissue volume content, and they established that dapagliflozin does significantly reduce interstitial volume, more so than intravascular volume. So you're getting rid of, you're not just causing hypotension and diuresing or dehydrating these patients. You're actually getting the fluid out from within the tissue, and it might be a more healthy way to actually cause or elicit a diuresis without all the negative impact of loop diuretics. So that's one mechanism that by which these drugs are thought to perhaps exert a benefit beyond that of glucose lowering. In addition, all of these drugs do lower blood pressure. As you can see in Empa Reg and subsequently in the Canvas program, both empagliflozin and canagliflozin do lower the blood pressure by about 5 or 6 millimeters of mercury. While that's been controlled out for and been shown not to be the primary thing responsible for the decrease in the cardiovascular or the improvement in the cardiovascular benefits, certainly we do think that that may play some role in the overall cardiovascular benefits that we see from these drugs. Also important to realize that you may see some lowering of the blood pressure with this drug. One of the more fascinating potential mechanisms by which these drugs may exert some of their cardiovascular benefits is by improving cardiometabolics. This is a huge field that's sort of blowing up now within cardiology, the study of the fuel substrate of both the healthy and sick heart and how we can potentially manipulate that for ultimate heart failure benefit. A healthy heart exists or functions primarily through a diet of fatty acids, glucose, as well as a little bit of ketones and branch chain amino acids. When the heart becomes sick, it tends to shift more towards utilizing glucose and less fatty acids, less ketones, less BCAAs. It's not clear if that's a product or if heart failure ends up as if that's a product of developing heart failure or if that leads to heart failure. But certainly the more glucose utilization, the more adverse remodeling we see in the heart, and subsequently it's thought that perhaps manipulating that may improve outcomes. And in fact, SGLT2 inhibitors have been shown to reduce the amount of glucose dependence and increase the amount of fatty acid and ketone utilization within the heart, and that's another mechanism by which these drugs may exert their effects. In fact, they've looked at specifically at, the reason I have a nice little pig wearing glasses here is this was a trial where they looked at pigs in whom they they basically gave all these pigs heart attacks and then put them on empagliflozin, and 2 months later studied their cells and their hearts and what kind of fuel uptake those hearts were using, or what the fuel substrate, the predominant fuel substrate that those hearts were utilizing in their daily function. And what we saw was that in the pigs treated with empagliflozin with heart failure, there was more free fatty uptake, less glucose utilization, much higher ketone body utilization, and much better lactate utilization. And that seems to be a more favorable metabolic profile than that which we see with a routine heart failure heart. And that results in better myocardial efficiency, as is represented here, and higher ATP content and higher ATP myocardial content. So it seems that by shifting back to a diet of mostly ketones, free fatty acids, and branched chain amino acids and less glucose, we're using a more efficient fuel substrate and thereby potentially benefiting the myocardium and decreasing adverse remodeling post-heart failure. And this is just, again, another picture just sort of demonstrating that exact concept. Another thing that the SGLT2 inhibitors demonstrate, or another effect that they exert, is their effects on the sodium-hydrogen transporter in the myocardium. This receptor, or this transporter, brings hydrogen out of these cardiomyocyte and sodium into the myocyte, and in doing so, increases intracellular calcium, decreases intramitochondrial calcium, and ultimately lowers ATP production. SGLT2s, by inhibiting this, increase the intramitochondrial calcium and thereby lead to increased ATP production, again, giving more fuel and making it more, producing a more efficient functional sort of environment for the cardiomyocyte. And so with all these things, we also see there was a recent study looking at MRIs on looking at patients on SGLT2 inhibitors versus those just on placebo. And what they saw there was a decrease in the extracellular volume in patients on SGLT2 inhibitors versus those on placebo. Extracellular volume is sort of the volume outside the myocyte that sort of represents edema, fibrosis, scarring, basically a lot of things that underlie negative or adverse remodeling that we see long-term in heart failure. The more ECV you see, the more adverse the remodeling, there is. And so by seeing a significant reduction in extracellular volume, we're actually seeing a reduction in the negative or adverse remodeling with heart failure, and that may lead to some of the benefits that I'm going to show you in just a moment. There's also benefits with regards to empagliflozin or SGLT2s in terms of their effects on the neurohormonal system. We see lower levels of norepinephrine plasma levels. We see lower BNP levels in patients on SGLT2Is. We also see lower levels of serum ST2. ST2 is a powerful indicator of fibrosis. It's a byproduct of fibrosis within the myocardium. And in patients treated with empagliflozin, we saw less ST2 or lower ST2 levels than those treated with placebo. And likewise, we see lower troponin I levels. We know that troponin I is associated with, again, myocyte destruction, adverse remodeling, worse outcomes with heart failure. Then we can't forget about the renal effects. Dr. Lerma went through all of this, and we know that there's profound benefits of SGLT2s on the kidneys, and that ultimately the kidneys on the heart are obviously best buds in most cases, most times. And if the kidneys are happy, the heart is happy, typically the other way around as well. So through all of its benefits on the kidneys, SGLT2s also utilize, the SGLT2s create an environment that is more healthy for the heart by increasing erythrogenesis, increasing oxygen delivery, decreasing inflammation, and ultimately that too is thought to play a role in all the cardiovascular benefits that we see with SGLT2Is. We have studies that show that SGLT2Is lead to a decrease in the inflammatory profile of patients with diabetes. That may lead to decreases in extracellular matrix turnover and fibrosis. The mechanism by which the drugs exert this effect is not exactly clear, but they do seem to be anti-inflammatory, anti-fibrotic, and therefore beneficial to the heart. So all of these things together seem to work together to exert the beneficial cardiovascular effects that we've seen through all the trials that I've already reviewed today. So again, it is more than just glucose lowering. It's pleiotropic. It's much like statins. These drugs are more than just what they primarily do. They do so much more for the body, the heart, the kidneys, and therefore improve outcomes overall. And this, in the end, leads to improvements in adverse remodeling. We have data that shows us that there is less post-MI, 2 months after an MI, if you look at the heart, these are again these pig hearts. If you look at pig hearts that 2 months post MI, you see that those treated with SGLT2s are less dilated. So this is LVEDD, or LVDV, the left ventricular end diastolic volume, and there's a significant reduction in the dilatation, both in diastole and systole, of patients treated with SGLT2is. There is an improvement in the LV mass, as identified here. And there's improvements in ejection fraction. I'm not sure which one of these is EF. I think it's on the next one. And also, one of the other things that we constantly look at as heart failure doctors is the sphericity or sphericity index, how globular the heart is. And we see that there's less of a sphericity, less of an impact of a in terms of the sphericity of the heart in patients or in pigs treated with empagliflozin as opposed to those treated with placebo or with controls, implying that, again, that these all contribute to that these drugs do impact the adverse remodeling that we see with heart failure. And this, again, ultimately impacts function. Here's the EF data. So we see improvements or less of a decline in the EF by CMR, better contractile reserve, better strain parameters, and again, when treated post-MI with an SGLT2 versus the control. So all of these play a role in the putative mechanisms of SGLT2 benefits in heart failure. So hopefully at this point, I've kind of built an argument for why these drugs do more than what we think that they originally did, and why these are actually becoming more cardiovascular drugs than anything else. So whom should we treat and how? So the SGLT2I should be considered in patients with diabetes who are at high risk for CV disease, those with diabetes who have established ASCVD, those with diabetes with proteinuria, that's credence, those with HFrEF independent of diabetic status, and those with HFrEF independent of diabetic status, and that's the last two trials I just presented. This has led to a few consensus documents that have recently come out in the last year. This is one produced by the ACC in combination with the ADA, and it goes through the individual recommendations in terms of indications, dosing, renal dosing, or at least dose modifications, contraindications, cautions. I won't go through detail, just to say that this document is out there to help guide you in terms of utilizing these drugs and who to use these drugs for. This is the highlighted there. And then likewise, with regards to heart failure, there was a 2021 update to the consensus decision pathway, just sort of looking at the optimization of heart failure treatment. And here again, we see SGLT2s finding their way into our GDMT. It's now considered sort of the fourth GDMT, along with beta blockers, RAS inhibition, MRAs. Now we consider SGLT2s to be the fourth line therapy for patients with heart failure reduced EF. So much so that you see here in our HFrEF stage C treatment algorithm, we've got ACEs and beta blockers, MRAs, and then likewise, you need to be incorporating SGLT2is on top of other potential drugs. And the impact was so profound that actually there was this recent article, another recent article in Circulation by John McMurray and Milt Packer, two of thought leaders in heart failure, who thought that we should go ahead and start to rethink how we even introduce these drugs. And rather than doing ACE, beta blocker, MRA, ARNI, and then an SGLT2, start right off the bat and go with the SGLT2 right from the beginning. Do a beta blocker, SGLT2, introduce the ARNI, then the MRA. Now, this is not yet, a formal recommendation by the ACC, AHA, HFSA, ISHLT, any of these organizations, but it's just a proposal that these drugs really need to find themselves not just from the back to the front. Should be early therapies that we introduce to our heart failure patients in order to reverse much of the adverse remodeling and ultimately prevent heart failure hospitalizations and improve heart failure outcomes. And that is this true is there was also a nice little document that you're welcome to look up that's actually specifically targeted towards cardiologists on how to sort of prescribe these drugs, what you need to look at, what their GFRs need to be, what other diabetic therapies you want to look at and potentially manipulate if you're thinking about initiating these drugs, how to follow, how to counsel. You know, I tell every single one of my patients, you know, you got to make sure you're practicing good hygiene. These drugs can increase genital infections, UTIs. You know, you'd be surprised how many patients don't bathe every day or even every week. The pandemic, people are bathing once a month now. So you really got to think hard and really guide these patients to keep an eye on their, or to maintain their hygiene and take care of themselves, because again, we know the risk of infection. Again, another practical paper, another sort of a guideline on how to practically implement these drugs when taking care of patients with cardiovascular disease. Here's just another list of just sort of the potential practical considerations and potential adverse effects. I'd say from a hypoglycemia standpoint, I'd say the only place where I get a little bit worried, these drugs typically do not cause hypoglycemia, and therefore that's not typically a concern. As you saw, the A1C benefit is modest. But you do, when used and combined with especially sulfonylureas, glipizide, and whatnot, you got to be a little bit careful, because of course those can precipitate hypoglycemia. I know those are pretty bad, basically like fourth-line drugs now for diabetes, but I've got plenty of patients who are still on them. So sometimes in those circumstances, I may reach out to the endocrinologist and ask them to help me in terms of maybe getting them off that so we can introduce an SGLT2 instead. So going back to my question at the beginning, SGLT2 inhibitors are rapidly emerging. They improve clinical outcomes in which patients? And the answer was, of course, A, B, and C. Those with diabetes with risk factors for ASCVD, those with diabetes with established ASCVD, and those, again, with heart failure reduced EF, independent of diabetic status. We haven't yet established their benefit in HFpEF, but that trial is ongoing, and hopefully we'll have some results soon. I think in April, they're hoping to wrap that up, and we may be able to learn more about the impact of empagliflozin on patients with heart failure preserved EF. So in summary, diabetes, CV disease, and heart failure are all common, intertwined, and deadly. SGLT2Is have been shown to improve CV outcomes in patients with diabetes who have risk factors for CV disease or established ASCVD. The benefits of SGLT2Is are primarily driven by reductions in development of heart failure and heart failure hospitalization. This drug prevents heart failure. SGLT2Is have been shown to improve outcomes with heart failure independent of diabetic status. They exert their effect through a myriad of benefits, including all those I've listed there. And they are rapidly becoming standard of care. And pretty much, as Dr. Lerma said, it's almost malpractice not to use these drugs in patients with heart failure reduced EF as part of your GDMT to recover and improve outcomes on your patients with heart failure. Now remember, but you always have to think about the risk of mycotic genital infection and UTIs. It's not, you know, I've got dozens of patients on these drugs. It's not like everyone's coming in with a UTI, but I definitely have seen it, and it can be an issue. You just have to deal with it, and usually it's not catastrophic. So I want to kind of give my deep thought. I don't know how old, if any of you guys are old enough to remember Deep Thoughts by Jack Handy. It was an old Saturday Night Live skit where they would give these really profound statements regarding the world events. But I'd like to argue that SGLT2Is are actually cardiovascular medications that also safely lower blood sugar, but that they, in fact, are more our drugs than his drugs. Okay, so that's Dr. Kokorian. Sorry, these are cardiovascular medications. We as cardiologists, you as doctors who are taking care of patients with heart failure and heart disease, need to know how to use these drugs. And you guys will be able to use these drugs. I know you're confident that everybody here is learning how to use these, but need to employ and be proactive. Talk to the endocrinologist, talk to your primaries, make sure your patients are on these drugs. These are improving outcomes, saving lives, they're reducing heart failure hospitalization, and it's part of GDMT for people with heart failure reduced EF. All right, and that's all I got. Thank you very much. I don't know if you have any time for questions. I've got time for this.
No. Okay, there it is. Thanks for that talk. That was super fascinating. I had two questions. One would be like, for the sole indication of HFrEF, do you find it difficult in your clinic to get insurance to cover this drug for that indication without someone with diabetes? And then also for your patients who, I'm assuming, you know, as an advanced heart failure doctor, you're probably seeing all those class 3, class 4 patients. Are you still using those drugs in those patients if they've already presented to you with that later class? Are you still adding these SGLT2s on?
Very, very, very good question. Number one, as far as the coverage, you'd be surprised because so many of the insurance companies already have these drugs, or at least one of them on formulary. You can actually, it's not as impossible as it seems to get these drugs covered, even for patients without diabetes with simply heart failure alone. Sometimes you have to use the formulary drug, and that's why it's nice to understand that there is something of a class effect. If I can't get, really for heart failure reduced DF, the data seems to be strongest for dapagliflozin, as I told you, the CV outcome reduction and as well as the heart failure outcome versus the Empa reduced and even the Invokana data. But if Invokana is the drug that's on formulary and the one that the insurance will let me use, I won't, question it too much as long as I can get them on some form of SGLT2I. And that's what I would counsel to you. Like, if you have trouble, try a different one, or try to figure out if one is one of the many ones that are out there is covered, because we're just seeing more and more data showing that this is more of a class effect rather than individual drugs. So I would say that the challenge is not as hard as it seems. And it's not as hard as it was with some other drugs in the past, and even today. Sometimes Entresto can be a challenge, but I have an easier time sometimes getting them on an SGLT2I. With regards to the more advanced patients, certainly, like, you have to be a little bit cautious and make sure that, this is not a patient who needs more advanced therapies right away, like a heart transplant or an LVAD. But we are not reluctant to try to employ these even in our class 3 and more advanced patients, because we do believe, even for all of our GDMT, we're sometimes trying to rescue or turn these patients around. And, not that this is the standard, but I've had patients on inotropes who I was able to improve because they weren't on meds, they present advanced, but you want to give their heart a chance. You get them on inotropes, you maybe get them on some of these meds, and then you can actually get them off the inotropes. Again, that should not be the standard, and I'm not trying to allege that that's what we're doing on a regular basis. But what I'm getting at is that every heart should have a chance to kind of reverse remodel and get better. You always want to try to see how much you can reverse, how much you can salvage the heart that the person has themselves. VADs, transplants, they're great for the people who need them, but we all know, especially you guys in this room who have rotated and seen, they are fraught with potential complications. They're very high risk. And if you can turn that heart around by improving its metabolic sort of profile, then that's a win. I've turned around patients like that, and I would say I would encourage you guys to try to do so as well. Yeah, go ahead, sorry. Yeah, that's a really good one, and because I have seen with my as I've been using these more, as opposed to drugs like ARNIs, where a lot of people were worried about the natriuresis and therefore backing off on diuretics, and I'm less enthusiastic about that strategy. I don't empirically drop their diuretics, but with some of my more euvolemic patients who seem to be doing fairly well from a volume standpoint, if I'm starting them on a SGLT2I, I will typically reduce their diuretic dose by about half because of the concerns for there's no question. Like whereas with ARNIs, some of my patients are like, yeah, I notice I'm peeing more, blah, blah, blah. Almost universally, patients on the SGLT2Is will notice an increase in their urine output, and there's much, in my opinion, in my experience, there is a higher risk of potentially volume depletion with the use of these drugs. So you do have to be a little bit cautious. I also check labs, like a BMP or a CMP, about 2 weeks after initiating it, again, to screen for potential prerenal dehydration, renal insufficiency, more due to that. And usually my modification, if I see it, is to back off on the loop, not necessarily stop the SGLT2. So there is data for the implementation of these drugs as an inpatient with regards to potential outcomes and benefits outcomes. The biggest challenge there is formulary. Many of these drugs are not on formulary, including, I believe, here. And therefore, we're fighting very hard with the P&T committees to try to get them on formulary for inpatient utilization, A, so that you don't have to discontinue them when they come in, and B, so that we can start them as an inpatient. The other downside or potential challenge you have to make sure you don't run into is starting it as an inpatient and then not following up in terms of getting them authorized. So they've got this drug, and then you tell them go home on it, and all of a sudden it's like, they didn't get pre-auth or prior auth. So it can actually be a good thing, because then you can employ your case managers, social workers to help you try to get those drugs authorized before you send them home on them, and you'll know any barriers that there might be to starting them on it. So I think that I would say that there's data to say that they should be utilized as an inpatient, and so I'd say that that's going to grow in terms of what you're going to see down the line. It's just like RNEs as well, same thing. Any other questions?
There's one question on Bill.
Sure.
Someone's asking, is there a long-term negative effect of persistent glucosuria? How high is the risk of urinary tract infection?
So the 40 years gangrene was the main, the sort of the perirectal gangrene, and I think I have it somewhere here in terms of the percentage. It's not common. I'd have to go back and see. I know it's a fairly uncommon side effect. I can't give you an exact percentage. I want to say it's less than 1%, but it's not particularly prevalent, and I haven't actually encountered it myself, and it's not something I really think about, other than if you have to, counsel patients if they start to develop perirectal or any sort of tenderness or pain, discomfort, that needs to be brought to the attention of your physician immediately, because that could be a potential side effect. As far as potentially the long-term harm of chronic glucosuria, I think that's almost a better question for either Dr. Krikorian or even Dr. Lerma, because I honestly don't entirely know, other than potentially, again, increasing the risk of urinary tract infections and those types of things.
Great. Well, in the interest of time, we really appreciate you presenting. Thank you very much. And thank you to all our attendees as well.
Thank you, guys. Thank you. I can't wait to hear yours, man. Thank you.
Really good.
Awesome. I appreciate it. Hopefully got all the data. And you can, the slides hopefully will be available or just distribute them as needed. Thank you. Awesome.
Thank you.
I'm looking forward to yours. I'll have a lot of questions.
I'll try.
I'll claim that this is an endocrine.
Oh, yeah.
Weak free talk there.
There you go. There it is. You guys have a better heart rate.